complications caused by IVUS. It's about when we are dealing, how IVUS helps us and dealing. IVUS, in fact, is the best friend whenever we are into some complications. How I'll tell you. This was a case in which a 3O stent was implanted and postnatal with 3.5 at high pressures. And this is what we landed up, even after doing everything 3.5 at high pressures. So is it underexpanded or not? Let's take the inner insight from the IVUS view. Though angiographically it was looking very underexpanded, but when we did the IVUS, what we find was, to say it's underexpanded, there are two criteria for stent expansion. Number one, the absolute MSA should be more than 5.5. And secondly, the expansion related to distal reference lumen area, it should be more than 90%. Here we see the absolute MSA is 6.5, that means more than 5.5. As compared to distal reference, the expansion is more than 90%. So first of all, this is not an underexpanded stent. It is an eccentric expansion, that is why it was looking underexpanded stent. So why was it looking underexpanded? Because in angiographically, what we see is that segment. It's a minimum lumen diameter, 2 millimeter diameter, that's what is visible in angiographically. But actually, the whole MSA is 6.5. So what matters is the absolute MSAs, not whether the expansion is concentric or eccentric, as in this case. Number 2 point, if you look at this segment, this is an eccentric compression. You can see there is the entire calcified plug is on one side and media is totally compressed. You hardly see any media here. You can see almost the adventitia is completely stretched out. Now, if you do something more heroic here, the entire pressure of the balloon is going to be transferred to that adventitia and not to the calcified portion. And we know the adventitia is a very fragile structure. So if we do something more here, it can lead to perforation. This is the case of impending perforation, this picture. So one should always see, whenever we see such pictures in which adventitia is completely stretched on one side and we see a calcified plug on the other side, this is a recipe for a disaster if you do something more. So next case is, what about IVUS in abrupt vessel closure? This was a case of anterior more than 24 hours. This was a culprit lesion. We went ahead with angioplasty. We dilated the 2.5 balloon. And after doing a balloon dilatation, there was an abrupt vessel closure. So we can have multiple possibilities here. It can be because of air embolism, because the balloon has ruptured. It can be because of slow flow. It can be because of dissection. It can be because of thrombus. And it can be because of spasm, because of barotrauma. Multiple possibilities are there. How to differentiate? Just put an IVUS. We put an IVUS. We found that this is because of severe dissection. Almost the alumina was occluded because of dissection. So once we have identified the cause, the treatment was very easy. So IVUS helps us in identifying the cause in a case of abrupt vessel closure. It's a wonderful device to see what has caused abrupt vessel closure. What about distal dissections? We have planted a stents. We saw distal dissection. So whenever we see a dissection on IVUS, we have to see for 5 things. Number 1, what is the extent of dissection? That means whether the dissection is extending up to the media or not. Number 1, what is the length of dissection? What is the arc of dissection? Whether there's associated IMH or not. Finally, what is the residual MLA after dissection? So if we see all these 5 things, all medial dissections, length less than 3 millimeter, arc more than 60 degree, IMH present, MLA less than 3.5, all these dissections need a restenting to prevent further vessel closure. IVUS also helps us in assessing stent edge haziness after putting a stent. This was a case in which osteoproximal stent was placed. We see some haziness in the just proximal to the stent. We don't know what is it. Just put an IVUS. When we put an IVUS, we found an hyperechoic crescent helmet-shaped homogeneous opacity between the two media. The media was split and this blood has accumulated within the medial space. This is nothing but intramural hematoma. Why does intramural hematoma occurs? Because in IMH, there's an intimal tear and the medial dissection, so the blood enters within the medial space, and because there's no space for blood to get out, so blood accumulates in that space and creates a false lumen, and that false lumen can compress the true lumen and occlude your vessel. So IMH is the impending vessel closure, and one must always recognize it. So this, and also not all IMH are worse. There are 5 IMH which are worse. IMH in which entry sites are not covered. All antegrade hematomas entering in normal segments, extramural hematomas, or when the vessel size is small. These are worst types of IMH, and that needs inevitable stenting to cover these, to prevent vessel closures. What about IVUS in impending vessel perforation? This is the picture, what you see. This is nothing but extramural hematoma. What is extramural hematoma? The adventitial dissection with accumulation of blood or contrast within the blood vessels. This is extramural hematoma. It means that the extension has got beyond media into the adventitia, and you can see spillage of dye in the adventitia. Now, if you do further post-dilatation or further dilatation here, it can perforate and can cause perforation. So, whenever you see extramural hematoma, this is a sign of impending perforation. Intramural hematoma is a sign of impending vessel closure. Extramural hematoma is a sign of impending perforation. So once we see this extramural hematoma, we need to stop here. We don't have to do further dilatation because this can be catastrophe and can cause perforation. Again, another case. This was done after RC stenting, and you see some outpouching within the stented segment. You don't know what is it. When you do an IVUS, you found that vessel is already perforated. You can see there's a break in the adventitia, but this is a contained perforation being contained by the pericardium, because that is why their blood is not extravasated in the pericardium. This is the contained pericardium. So this can be easily picked up on IVUS. You see a break. You see the break in the media. You can break in the adventitia. You can see, and this collection has formed outpouching, which is contained by the pericardium. Whenever we do CTOs, we are confused as whether the wire is in the true lumen or the false lumen. IVUS is very simple to differentiate. If you are in a false lumen, the lumen will appear foggy. There will be no branching from that lumen. The lumen will be false. You can see absence of 3 layers, it's false lumen. You inject dye, if the dye stagnates in that lumen, it will be false lumen. The dye will stack in the false lumen. And if it's non-pulsatile, it will be false lumen. So true lumen are pulsatile, they will be branching, they will be non-foggy, and they will have 3-layer appearance. This is how we differentiate between a true and a false lumen. What about IVUS in aneurysm? We see sometimes these types of cases. To differentiate between a true and a false aneurysm, IVUS is very easy. If you see a medial discontinuity, that means you don't see triple layers. That means this is a pseudo-aneurysm. 1 layer is missing. If you see all the 3 layers, that means it's a true aneurysm, because management may differ between true and pseudo-aneurysms. So this we covered with a covered stent, and whenever we implant a covered stent, we see this eclipse sign. Eclipse sign means because this covered stent has a PTFE graft, and ultrasound waves cannot penetrate the PTFE graft, so you see nothing beyond that. It's like an eclipse, total eclipse. That is why it's called an eclipse sign, both in OCT as well as in IVUS. What about when we are doing a crossover stenting? We do ostial stenting very often. We do a crossover stenting, and once we do a crossover stenting, what we find is the circumference is getting pinched. Again, we are in dilemma. What is it? What is causing this? What is happening is, you don't have to don't get confused. Just put an IVUS catheter. If the IVUS catheter is put, an MLA is more than 4 millimeter, usually it will not require stenting for all practical purpose. But here you can see we have put an IVUS. We found that this is a carinal shape. You can see the geometry of the circumflex ostia has been disturbed. Though the MLA is preserved, it's almost 8.6. So why it is looking like pinch? Again, the same philosophy. What we are looking at is a 2.3 diameter vessel of a 4.5 millimeter diameter, because it's a carina has been shifted. In angiographically, we look at only this segment, so it is looking like a pinch, but actually the whole MLA is 8.6. So whenever we do physiology, FFI in these cases, almost all times it comes out to be negative because the MLA is preserved. So what matters again is the residual MLA, not what the diameter on angiography is looking like. So again, IVUS is a wonderful modality to assess the side branch pinching whenever we do a crossover stenting. I think in all left main stenting, IVUS is a wonderful modality. Can I take 2 minutes? Yeah. Because LSD, longitudinal stent deformation, can be missed on IVUS. How to identify it? You see multiple stent layers. You see crowding of stent starts near the ostium. Once you see this, it is LSD. It is one of the indicator, one of the marker for poor long-term prognosis for stent failure, which cannot be picked up on or angiographically. Again, whenever we do in complex cases, we insert wire multiple times, wire comes out multiple times. So IVUS again is a wonderful modality to pick up abnormal wiring. Here in this case you can see not only the wire is outside the lumen, in fact the IVUS is also outside the lumen because the wire came out before port, and once the operator rewired it, and then the IVUS also went abdominally. Also, IVUS is a wonderful modality to pick up cause of stent thrombosis. This is the case of infibulumi. Successful primary angioplasty was done. After 7 days, again, the patient landed up with an acute stent thrombosis. He was thrombolized and referred to us. And though the vessel was flowing, but we see a lot of thrombus here. We did an angiography, we did an IVUS. What we found was it was a grossly undersized, underexpanded stent. The angiography was looking normal. You can see the MSA was only 7, but the vessel area was almost more than 20. When we compared with the distal reference lumen area, it was only 60% expansion. It was grossly underexpanded, undersized stent. So this time we did with IVUS guided procedure. Now you can see angiographically, if you see almost both the pictures are looking almost the same. But you see the IVUS, the MSA is achieved in the first procedure was almost 7, and here it was almost double, almost 12.5. This is how IVUS can make such a huge difference, and because ultimately what matters is not the angiographic image, but what the MS is, what we have achieved. Last case, this is a case of osteoproximal RCA. We did an RCA stenting, though this was not IVUS guided with old days. Again, after 3 days, again patient landed up with acute stent thrombosis. We did the IVUS. We found that this ostium was not covered. How to identify on IVUS whether ostium is covered or not? Just pull back the IVUS, and the moment you see medial discontinuity, this is the point ostium is being shown. If you don't see stent studs there, that means ostium is not covered. Here you can see there's medial discontinuity. You don't see the media, and stent studs are not visible. That means that means the ostium was not covered. However, this time we covered the ostium. Now you can see the difference. Here we can see the stent studs are seen in the place where medial discontinuity is seen. That means ostium is covered. Whereas in the first procedure, ostium was not covered. I think IVUS is like the glasses of modern day intervention cardiologists who do not like to have blind decisions. And thank you IPCI for the opportunity. And I have this book on IVUS I to Z. Those who want is available in IPCI in one of the stores. You can take it. Thank you.
Thanks very much for that whirlwind tour of very nice images. I think we're going to be behind time, so I'm going to keep my question brief. You talked about dissections that are worrisome, right? And the characteristics, an arc over 100 degrees, length over 7 millimeters, the presence of an IMH. I guess one of the challenges we have is contextualizing these things, because you have 6 different factors, and I'm sure you'll agree that if you see one of those things in a limited fashion, it doesn't portend a terrible prognosis. How do you add up? How do you create a decision out of all of those factors that say, I need to stent this person? And is there a role for waiting and watching?
This is a wonderful question, because sometimes you can see the length of the section is more than 5 millimeter, but the MLA is preserved. Sometimes it IMH present or not. I think the 2 most important factors which I consider is presence of intramural hematoma, number 1, and the residual MLA. If the MLA is less than 3.5, IMH is present, I think I usually put a stent.
That's fair. Great. Thank you very much, Dr. Manoria. That was very helpful.